Thank you very much. I'd like to start by thanking all of you for being here today at the second Colorectal Cancer Summit. This morning we're presenting some new data for cancer care in Victoria. The aim is to assess colorectal cancer incidence, survival and treatment across Victoria. We hope to ensure clinician engagement in improving outcomes, experience and care for people with colorectal cancer. We also hope to bring some content and context to policy making and to identify some areas of variation and just perhaps explain why. This presentation is the result of some work done by the Working Party that you can see on the slides, and with the assistance and direction of analysts from the Cancer Council and the Department of Health and Human Services. I'd like to especially thank Luke and Ella for their patience with us. The aim of the summit is to identify unwarranted variations in care for colorectal cancer. The data and presentation is a starting point for discussion, and it's for all of you to decide on the issues that you think are important. It's presented from a statewide perspective, but we would anticipate that local action is required to address any issues raised. The summit's not just about talking. We'd like to think that it'll result in some doing. So the full cycle of action should look something like this. We identify variations today, we investigate these locally, we change what needs to be changed, and we measure that change locally and statewide. You know about the optimal care pathway, and just a reminder that we'll be concentrating on these three aspects of the OCP. There are multiple classification systems of cancer staging. The VCR derives stage at diagnosis by applying the American Joint Committee on Cancer T&M staging principles. The information to inform the specific T, N and M components for the staging is a best estimate derived from summary sources at the time of diagnosis, which is defined as a 4-month period following the first notification of a cancer diagnosis. Hence, it's a combination of clinical and pathological data used for deriving the stage, according to some established rules. Occasionally, hospital notifications are the only source of information regarding distant metastases, which may result in some underreporting of stage 4. There's also a potential data bias favouring early disease, as radiological evidence of advanced disease is not necessarily available. You'll all no doubt be aware that there are 8 integrated cancer services, 3 metropolitan and 5 regional. The integrated cancer services are Victoria's state-funded programs to integrate cancer care. They involve linked groups of health services and clinicians working across organisational boundaries, focusing on the needs of the population to improve access and quality. Data in this presentation are analysed at 3 levels. Firstly by X of residence, but also by X of treatment, and lastly by campus of treatment. I will be calling them X from now on. So let's look at some data. We'll start with the basics. The incidence of colorectal cancer is diminishing over time since 1982, probably most convincingly in the male population. However, males remain slightly more likely to contract colorectal cancer. This slide demonstrates the incidence of colorectal cancer across the X. Here we can see the standardised incidence of colorectal cancer is clearly higher in regional Victoria. Moving on to patient demographics. The key points here are the median age at diagnosis is 71 years old, 54% of patients are male, 24% of patients are in the most disadvantaged socio-economic group. However, the percentage is clearly higher in the regional ICS. 73% of patients had no other comorbidities prior to their cancer diagnosis, and there's not much variation in that across the ICS. This slide demonstrates more clearly that there is variation in socio-economic spread across the ICS. It's clear that the lower socio-economic groups are more represented in the regions. However, this graph shows that there's not much variation in stage at diagnosis across the ICS. Here we've divided the stages into two groups, those with distant metastases and those without. Except for Grampians, where there seems to be an elevated proportion of stage 4 patients, which is almost statistically significant if we compare all ICS, but is statistically significant if we compare Grampians versus all the other ICS. Except for that, there's no great variation. Over the last 30 years, the 5-year survival for Victorians with colorectal cancer has increased from 49% to 69%. So something's going right. I'm sure you all have opinions about what that is, whether it's screening or better surgery, better perioperative care, or better oncology. It's probably a combination of all these things. These are hazard ratios for each ICS of residents and are compared to the Victorian average, which is the black line at 1. The lines extending from the black dots are the 95% confidence intervals. Patients who live in ICS with hazard ratios greater than 1 have poorer survival compared to the Victorian average. Patients who live in ICS with hazard ratios less than 1 have better survival compared to the Victorian average. The hazard ratios have been stratified on age, sex, socio-economic status, stage, year and comorbidity index. Therefore, estimates take into account all these variations across the ICS. Where the 95% confidence intervals don't cross the average is a significant variation. And on this graph, it looks like LIMIC's survival for colon cancer is a variant. This slide further analyses the survival for colon cancer patients across the ICS. What we notice is that it appears that any variance in the survival for LIMIC's colon cancer occurs in stage 4. There is no significant variance in survival for stage 1 to 3 patients. Emergency presentations with colorectal cancer is associated with poorer outcomes. We presented some data on this at the first summit indicating just that. The emergency presentation rate can be influenced by a number of factors. There are patient factors, for example, delayed presentations. There are primary care factors, such as distance to travel, long delay for appointment, or failure to act in a timely manner. And there are specialist and hospital factors, such as waiting lists and waiting times for outpatient appointments. These are data from the 2011 to 2015, and note this is for first colorectal surgery. The slide indicates increasing rates of emergency surgery. Emergency surgery is for patients who are classified O or C on admission. Not such a good trend. Patients may have better outcomes if surgery is planned rather than an emergency. Surgery performed in an emergency setting may indicate late or misdiagnosis. 3% of stage 1 colorectal cancers received emergency surgery compared to 27% of stage 4 colorectal cancers. These data indicate emergency surgery for first colorectal surgery is more likely in a couple of regional ICS, but also in WICMICS. At the first colorectal summit, we presented data revealing that a high proportion of these emergency cases had sought medical consultation in the period leading up to their emergency presentation. Over the last 2 years, most Victorian GPs have been, as Kathy said, educated in colorectal symptom recognition and referral pathways as part of the OCP implementation efforts. We'd like to think that the rate of emergency surgery should start trending down in Victoria if this has been effective. Looking at treatment planning, you've seen this graph or something like it. It's a graph showing that several of the integrated cancer services are yet to achieve the target of 80% for MDM presentation. This is an audit that was performed in 2015. I can inform you that many ICS and MD teams, my own included, have been having feedback about this data and efforts have been made to improve that. It might be useful to audit this again later this year. As mentioned before, at the first summit, one of the recommendations was that rectal cancer patients should be presented to MDM prior to commencing treatment. And this slide reveals that we have a lot of improving to do. At least in 2015 we did. My own network in SMICS is failing badly in this regard. In this section, I'm going to present some data on variations of utilisation of treatment and some indicators of quality of care. This slide demonstrates the odds ratio of receiving a particular treatment modality in the first year following the diagnosis compared to the Victorian average by ICS of residence. This is adjusted for age and comorbidities. Patients who live in an ICS with an odd ratio greater than 1 are more likely to receive that treatment modality compared to the Victorian average. Patients who live in an ICS with an odds ratio less than 1 are less likely to receive that treatment. The thing that's notable about this slide is the number of significant variations. One is 4 times more likely to receive chemotherapy for rectal cancer in WICMICS than in Barwon. About a third of the number of rectal cancer patients in GICS get radiotherapy compared to other ICS. There's similar variations in colon cancer. Compare GICS and BISWICS rates of chemotherapy administration. I'll let you ponder that for a minute. Focusing here on rectal cancer, it looks as if BISWICS might be giving more short-course radiotherapy and significantly less chemotherapy compared to the rest of Victoria. But it's also worth focusing on the fact that WICMICS is administering significantly more chemotherapy, more adjuvant chemotherapy. And GICS is certainly an outlier in terms of neoadjuvant treatment. We're moving on to lymph node harvest in colonic resection. This does not include rectal cancer. Lymph node count in excess of 12 is considered an indicator of surgical quality, and I would suggest also pathology. The histogram is showing the distribution of lymph nodes examined, and the red line equals 12 lymph nodes. On the right, we see the change in proportion of patients having 12 or more lymph nodes examined according to the year of diagnosis. And that's increasing. Good news. There's also the same graph with the stage, and you can see that stage 2 and 3 have more resections with 12 or more lymph nodes, and stage 4 less. That's not so surprising. Here's a graph of lymph node harvest by ICS. In this case, we can include Hume without reservation, as this is for resections performed in that integrated cancer service. And Hume is a significant outlier in this regard. These are data from VCR. The node data is linked to the campus of first surgery and is restricted to surgeries within 120 days of the diagnosis date. And these campuses are doing small numbers of resections with significantly below par node counts. Now we're looking at adjuvant therapy for stage 3 colon cancer. One of the issues with the chemotherapy data from previous slides was that it didn't include oral chemotherapy given on an outpatient basis. This slide has been linked to PBS data to include oral chemotherapy. And even with that linkage, there is a clear outlier still. This slide demonstrates the same data by campus rather than ICS, and this hospital is treating colon cancer patients differently to all other hospitals in Victoria, and its volume of cases is mid-range, they're not small. In general, it's desirable to commence chemotherapy for stage 3 colon cancer within 56 days. In this slide, the difference between public and private patients is a little disappointing and may reflect pressure on valuable resources. WIC-MICS and JICS are achieving timely chemotherapy in only 50% of cases. We saw previously that stage 4 colon cancer patients in the Loddon Mallee had poorer survival. This slide reveals that treatment utilisation of surgery, chemotherapy and radiotherapy is not statistically different for stage 4 colon cancer patients living in the Loddon Mallee compared to the Victorian average. So we don't know why that variation occurred. So I'm going to try and summarise what we know so far. The incidence of colorectal cancer remains higher in regional Victoria than in the cities. More emergency surgery is being done for colorectal cancer, and there are large variations existing in chemotherapy use. We need to improve MDM discussion rates for our colorectal patients, and we need to present rectal cancer patients pre-treatment. Rates of adjuvant chemotherapy vary significantly across the state. Neoadjuvant radiotherapy for rectal cancer rates show marked variation, and there is also variation in lymph node harvest and pathology reporting of nodal counts, which may need investigation. Adjuvant chemotherapy is not given in a timely fashion in all regions. That concludes my presentation. If you have any questions, I'm happy to take them, and if I need statistical help, I'll refer them on.
Is there any slide about the 5-year survival depending upon the each X for the colorectal?
I'm sorry?
Is there any data about the 5-year survival according to the each X and staging?
Yes. Sorry. We do have information about survival by X by stage, and for colon cancer we thought that data was reasonably robust, but we had a difficulty with rectal cancer, and that was that the staging was a combination. Some people had their staging done post-operatively from histology, and some was done by information on clinical information, pre-treatment. And so we had a mixture of patients who had neoadjuvant treatment and had been downstaged, and so it just confused the staging so much. And what we chose to do was because we couldn't present that data for rectal cancer, we divided it into those with metastatic disease and those without, and then we could include rectal cancer in with the colon cancers. So that was the reason for that. What we noticed when we looked at the staging for rectal cancer, there were I think over 20% of people with stage 1 rectal cancer getting neoadjuvant treatment. And so what that meant to us was that they must have been downstaged, and so the staging was meaningless.
Finlay McRae, the currently revised NHMRC guidelines have pointed to a longer allowable time between presentation and surgical management than has been conventionally considered appropriate. So I'm wondering whether there's any data here that on the delay between presentation and treatment with respect to the outcome of staging and survival.
So that's, I don't think, Luke, did we have any information on that? I don't think we had anything.
Ian Skinner from WICMIX. There are two questions I have, Brian. First is, while we see stuff which has been talked about at MDT and stuff that's been referred through pathways, we see a significant number of patients anecdotally that are going outside pathways and going outside treatment through the ICS. Do you have any data about how those patients are being treated and what quality is being provided to them? And secondarily, with the data that you've got, which is mainly administrative data, what processes have you used to ensure that the integrity of that data is absolute in terms of audit against local and regional data?
So just to start with the second, we think the data's reasonably robust because it's VAED data, and so there's a pressure on organisations to get that right so that they can be funded appropriately. But we haven't compared it against any other database. We've just linked these databases we've mentioned. And just the first question again. We've had, because it's VAED data, we could access people who are doing low volume stuff in smallish hospitals. We did that last time at the last summit. That's possible. We haven't exercised. We haven't done that this time. But we did look at that last time. There was a number of places doing very small numbers of rectal cancer operations and colon cancer operations. But we haven't matched them to outcomes.
Yeah, Mark Warren from Bendigo Health. So I guess with stage 4, it sounded like we had incomplete data, maybe more so than stage 1 to 3 in terms of staging. Are we able to get things like right versus left side, BRAF mutation status, RAS, which is now pretty standard information, proportion of patients having curative metastasectomy and things like that, to help try and tease out outcomes and the variation?
I think we could access certainly right side versus left side without too much difficulty, just because they're on their item numbers, and probably curative resections as well for metastases. And we did drill down a little bit into that during our summit discussions. So we could drill down a bit further if that was what was required.
It's Alana. Oh, hi. It's Alana here from LMIX. So we got the heads up on this variation a couple of days ago. It's actually triggered some really interesting conversations already within our ICS, and we've set up a working group. We've got 10 working theories about why we have this variation. Some of it's data, some of it's there could be a problem. About 30% of our treatment isn't in our ICS, so it's going to be a very fascinating journey to actually find it out. So, I think the feedback is very positive about getting this kind of information. Good.
Brandon, just one more question to ask is, if you look at the data so far presented, is there any further information available about the outcome of the patient depending upon the access to the clinical trials within that organization? Do that equates to the survival benefit for even non-clinical trial access, non-clinical trial cohort of the patient? For example, stage 2 colorectal cancer, which probably may not be a part of any clinical trials, but access to the trial within that institution, do they reflect anything in the patient's survival?
I've not seen anything on that, not on clinical trials, no.
Is there any plan to look into it? Is the working group will look into
We certainly hadn't discussed that, but we can talk about it. Thank you.
So just a round of applause for holding all that together and remembering that.